special program for all of us and our benefit and our education and discussion on the topic of spine trauma and the curveballs. This is a particularly cool group of colleagues, and it's so exciting to have you both back again. So, Emmanuel and Bob, we're looking forward to your cases and our discussion. So, thanks for taking on this program, and welcome to everybody. And we want to thank Spine Art for the generous educational support.
All right, good evening, everyone, and thanks for having us again. And I'm Emmanuel Menga. I'm currently at the University of Miami, previously of Rochester, New York. And I'll be presenting with my co-presenter, Dr. Molinari, who's a mentor and a dear friend. I've known Dr. Molinari since I was in medical school at the University of Rochester, and I was with him as a partner for over the past 7 years until 6 months ago when I joined the University of Miami. So I'm honored to be here with him to present. I would like to thank the Seattle Science Foundation for inviting us again to join you to present our talk. So this really is all about Dr. Molinari. This is supposed to be his lifetime experience with dealing with complex spine trauma and interesting spine trauma cases. So I'll present 2 cases, and I'll leave the floor to Dr. Molinari to present his cases. These are my disclosures, nothing related to the current talk. And I'll go directly into some trauma. So this is a 23-year-old. So these are the types of traumas we saw in Rochester. The cases I'm presenting are really cases from my time in Rochester before I left 6 months ago. So this is a 23-year-old patient who came in 3 years ago. MVC, typical day, finishing up clinic at 4 p.m. and I get a call from the residents. We have a patient with a bad jump facet in the lumbar spine, and I thought the resident was mistaken. I said, "Are you sure it's not the cervical?" I said, "No, it's a lumbar spine," which is I'd never seen before or even read about before. So MVC presenting with abdominal pain, back pain, and leg pain, severe radiating pain to the bilateral lower extremities, numbness and tingling throughout the bilateral lower extremities, urinary retention. So the trauma team was concerned about mesenteric injury and took the patient to the operating room for an X-lap. There was no active bleeding, but some hematoma. So they cleared the patient for us to proceed with the spinal surgery. So I'll go over some slides, critical slides showing this is moving from the left side to the right side, and you can see the bilateral jump facet. The MRI was not ideal because the patient was moving because he was in so much pain, and he was moving during the MRI. This is prior to his X-lap. And so opted to take the patient to the operating room. And this is a 23-year-old patient. I'm trying to figure out how do I minimize the number of levels I have to do? How easy is it going to be to reduce this jump facet? We know even for cervical spine, it's not always easy. And then imagine for the lumbar spine. So took the patient to the operating room, and the spine, one thing you fail to appreciate on the CAT scan and the MRI, it's not just a jump facet, it's also rotated. And attempted to place the screws, attempted to reduce it, and the thing was not moving. It wasn't going anywhere. And decided to take down the facet joints. And as soon as you take down the facet joint, the spine goes into almost a pretty significant rotation. And you see the thecal sac rotated. And one thought process was, should I add 1 or 2 more levels so it allows me to reduce, almost like managing as a scoliosis case? But I was still not I still didn't want to fuse multiple levels on a 23-year-old patient. And one thing that was also significant was the degree of disruption of the soft tissue. The intertransverse ligament was completely ripped apart, and you were staring directly at the nerve roots. And so there was no surface area to place bone, and we resected the facet joint. So placed the screws and was able to play around with it. Finally was able to get some correction of the rotation. You can see the spinous process is off at the superior level compared to the bottom level, but at least got some adequate, for what we felt was adequate reduction. Now, the other challenge is, do I go in, and at this time, general surgery is completed X-lap and or laparoscopic X-lap, and we're thinking this is more of a damage control surgery. Decompress the spinal canal, decompress the nerve roots, and we're still, and trauma had recommended we don't take too long in the operating room, and we're staring at the nerve. There's no surface area to lay down bone for fusion. And the question is, do you take some time that which could be quick and do a T-lift, or think about adding something from a lateral procedure to get a surface area for fusion? So I opted to, because of the time it took just to rotate the spine and get the rod in there, I opted to just abort after decompression and instrumentation posteriorly, and then brought the patient back a day late, I think 2 days later, and did a lateral procedure. And here's the patient 2 years out, and he's attained fusion at that level with 1-level surgery.
Hey,
So
Emmanuel,
let's
hey,
go back.
go back. This is very cool. This is now my question that I have is not necessarily towards you, but towards the general surgeon. I know we're all spine surgeons here, but so this was a lap belt injury, wasn't it? I mean, this was the patient who had a fulcrum type deceleration trauma. Why did the general surgeons do a lap on him right off the bat? Did they not do ultrasound or an abdominal CT or something? I mean, that's a very unusually aggressive approach that then you're called in to kind of do the spine surgery. Can you tell us A, accident mechanism, lap belt, etc., and then B, why an exploratory laparoscopy? Is that a new protocol or what went on there?
yeah, it's I think it was the same question we had. Because it said, well, we have a CT scan. It's not clear whether or not, which I don't know if it was because of the motion. They said, we think there's a hematoma. We're not sure if he's having an active bleeding, but he was hemodynamically stable. And I think they did this out of caution. They opted to just take him and do a quick, they said it should be quick. We're doing it laparoscopically. And so that's why they opted to do it before we took the patient in.
Yeah, thank you. It's just not a approach that I'm familiar with. Most general surgeons and trauma surgeons I know nowadays don't want to operate on patients anymore. They like to get scans and put tubes into patients, maybe, but that's actually very decisive, and I've just not heard that before.
Yeah.
So I love this. I mean, I think that you're struggling. This is a type C injury, so I'm an AO guy. Like
Yeah.
I think all of our Texas friends are AO people. Also, this is a classic type C injury. And again, the dogma there is 2 above, 2 below, but I think that in a young patient in the lumbar spine, that's a really big deal. And you said it, the concept of damage control surgery is brilliant. We don't need to do the whole shebang. We need to get the spine realigned as good as we can, get the nerves protected. With a young patient's bone quality, a short segment fixation is fine. Then you hit the home run with a nice far lateral surgery. So, I mean, I don't know what my colleagues in Texas think, but I think this is brilliantly handled all around.
Emmanuel, how was he neurologically before and after? Was the dura split open or was the dura intact?
Luckily, the dura was intact. Besides the rotation, once we were able to derotate it, it was still slightly rotated. But no, he was neurologic. Besides his pain, he didn't have any much weakness. It was just right.
Emmanuel, Emmanuel, well, why did you have such a difficulty getting him rotated? I see he's still off a little bit and it looks fine, but I'm just curious, was it just that he was so darn unstable or?
Yeah, I think it was unstable. Most of the soft tissue and the interligament, the ligaments were all disrupted. And then once we took down the facet joint, it rotated even more because there was no stability posteriorly. And even I suspect some of the disc space was also damaged given the degree of injury he had with the jump facet. So I think he had rupture, both even disruption of his disc space, which is what made him so unstable.
Manual, with the transverse processes intact at each level?
I think above was intact, below was not.
Because what I would propose is in younger people, what I've had success on, and Jens, I know you've done this too, is to do your reduction by however you're going to do it, whether you had to take a facet down or not. But in younger people, what I do is I'll rod long and I'll fuse short. So I'll put in screws above and below, however many I need, 2, 3 levels, it doesn't matter. But I'll go back at 4 to 5 months. I'll just do my bone grafting over the dislocated level in young people. And then I'll come back at 5 months and I'll cut my rods and I'll take my screws out and I'll permit motion at those other levels. So it's just another way to do this, all posterior with a rod long, fuse short technique.
In 14 years at Rancho, I saw a lot of flexion, distraction, injuries, but I don't think I've ever seen jump facets like that in the lumbar. I was going to ask, Bob, have you seen that before? That's
I have. I've seen it at, believe it or not, at the lumbosacral junction. I've seen this. It was actually, spinal pelvic dislocation. So we've seen them. They're not very common. We would agree they're not very common, but they do occur. And when they occur, I think what Emmanuel did, taking the facets down, really helps with the reduction.
And Emmanuel, was the disc damage? I mean, was there disc material back in the canal after the reduction, or you think that stayed clear?
No, I didn't see any evidence of disc material within the canal itself.
Because you always have to wonder at the moment of injury, there was probably much more significant deformity than you saw here. So anything goes with the middle and anterior column. So, considering how unstable this was, A, he's lucky that he stayed neurologically intact, and B, you did a very good job stabilizing him and leaving him a good lumbar spine for the rest of his life. So good job.
Emmanuel, one more experiential question. That is, so you followed a posterior open reduction of a undoubtedly high-grade injury, a high kinetic energy injury with an open posterior surgery. How much bleeding was there after the general surgeon had just finished the laparoscopy? Was it torrential or was it very controllable? What was your thought and experience there?
No, it was very controllable. Yeah, it wasn't too much bleeding. Besides the muscle bleeding from the disruption of the paraspinal muscles and the transverse ligaments, the bleeding was well controlled. I think dealing with the same approach we would take with managing patients with deformity or high risk patients with using TXA and keeping the map controlled during the surgery and also taking the time with the exposure. I think that helped a lot. So, but no, the bleeding wasn't that bad.
And
So
Emmanuel, that was a great graft you put in there. I mean, you filled that space up completely. What was the size of the anterior posterior dimensions of the graft?
I think anterior posterior, I'm not sure. I think it was maybe about 12 millimeter anterior posterior. Yeah, so it's just a lateral titanium cage, expandable cage too.
Looks
Matt,
great.
let's just say it's a younger patient and the patient wants to go back to participating in sports. You're going to let this patient participate in contact sports?
That I'm not sure.
Analysts?
Oh, I'm sorry.
Anyone on the panel? Manny, anyone on the panel?
No reason not to. If he's got a solid fusion there, and no reason to restrict him at all.
I agree.
You know what? I'd be a little concerned because he has, other than the rods, there's no posterior stabilizations. He's got a nice inner body fusion, but I would be a little concerned if it was my kid.
I've talked to guys that do high grade sports medicine with these kind of constructs, and once you're fused, you're fused.
Yeah, I think you have to prove your fusion, at least in my hands. I would prove the fusion with a CAT scan at some point, 6 months, 9 months, a year later, at least, maybe wait a year, make sure that fusion is solid, especially the posterolateral fusion. I'd make sure it's solid. And then I agree 100%. If the level is solidly fused, the other levels are fine, I would let the patient go back to sports. Yeah. I would try to discourage them from contact sports just because we really don't have great data on that. But I would permit sports participation.
Yeah, I don't disagree about sports, but I'd be concerned about the contact. Emmanuel, I thought you said that it was hard to do a posterolateral because everything was just torn apart and you're looking at the roots. So did you do much posterolateral, or you?
No, there was no surface area to lay bone. It was looking directly at the roots.
So basically, you're depending on just the inner body, which looks great. And as you said, Bob, you get a CT scan, but I'd still be concerned. I mean, the pedicle screws and rods are great, but they're not live tissue that can remodel against stress. So.
Yeah, I agree. I think we all agree there has to be a solid fusion, correct? I think everybody in the panel agrees with that.
Yes.
Is he from a deformity guy? Would you have used more hardware to derotate it? Would you have been more aggressive at getting better leverage? And whether you left long fusion in or not, would you just mechanically have worked more on that, do you think?
Were you asking that to me, Jack?
I was, yeah.
I would not go longer on this. I would work as hard as I can, much like Emmanuel did, to get it as close as possible, just those levels. We know how critical the lumbar spine is, and I wouldn't want to dissect any more muscle above and below. There's already a lot of damage done at that index level. Going above and below, you're just inflicting more injury.
Thank
Okay,
you.
Emmanuel, I have one complaint.
All right.
Crosslink. So this is like just almost irrelevant, but in a highly unstable spine with a short segment fixation, what are your thoughts on a crosslink adding just that until you have that crucial anterior, beautifully placed far lateral cage in? What about crosslinks? You did a full, nice posterior decompression. Does that add something meaningfully or not?
I think in retrospect, I would have done it. The only reason I didn't do it is because I rarely use crosslinks. So it's not in my head it's not in the back of my head to use it. So, but in retrospect, I probably would have used it if I used it often.
An honest answer.
I
That's
think we
fine.
all would agree. We all would agree, right? We would probably pop on a crosslink for additional torsional stability.
Yeah, especially not knowing, you plan to go back, but sometimes you can't go back. You do the case and you plan to go back, and then you find out the patient is not stable to take them back to surgery anytime soon. And I think that certainly would have helped with the rotation. But it's just I just don't use crosslinks very much, and it wasn't in my brain thinking about crosslinks. Yeah. Yeah, he went back to snowboarding at least a year out. So a little bit of contact sports.
He was lucky with the injury and lucky to have you as a surgeon.
Thank you. All right, I'll go to the next case here. Before I get this case going, I'll tell you a story. When I was interviewing for medical school in 2008, I sat in the room with Dr. Molinari. I was a student at the University of Rochester, and Dr. Molinari was telling me a story how interesting spine surgery was. And you all know Dr. Molinari, and Dr. Molinari is going, Manny, the guy's head was literally separated from his spine, and we had to put it back together. So I was sitting there, as a medical student, you don't understand the concept of occipital-cervical dissociation. So with Dr. M telling me that the patient's head was separated from his spine, I'm thinking the head was literally off his spine, and they put it back together. So every time I see a patient with OC dissociation, I think about Dr. M. So, and in practice, I've been in practice 10 years. I think I've managed about 5 or 6 of this, which is a rare trauma. I think that's been at a level 1 trauma center. So thanks to Dr. M too for being around to mentor me through some of these cases.
Thanks, Manny.
Yeah. So this is a 73-year-old male who presented with a mechanical fall, neck pain, airway concern, and he was intubated in the trauma bay because of airway concerns and difficulty breathing. He reported no radiculopathy at the time. He had a fixed hip and knee locked in from a previous girder stone over his bilateral hips, and had normal strength with the areas of motion, diagnosis of Eng spondy. And as you can see, he has his fracture through C2, but his entire spine is fused from his Eng spondy, including his occiput to C1. So technically, this occipital-cervical dissociation more at the C2 level rather than the typical occipital-cervical dissociation. So he was intubated in the trauma bay for airway protection. Patient went into cardiopulmonary arrest when they attempted to get an MRI. So he had to be resuscitated in the MRI suite with CPR, transported back to the ICU, and then 2 days later was able to complete the MRI to fully evaluate the injury. Here are the CT scans. And you see the gap in right there at the C2 level. And here's the MRI with severe cord compression, but luckily he was at least neurologically intact from what we can get from him, being intubated and with a fixed joints and limited motion throughout his joints, most of his joints. So once we had the MRI, took the patient to the operating room the day after we obtained the MRI, and with medical clearance from our trauma colleagues. Pre-flip, we obtained SSCPs and MEPs, and everything was normal. At least we had good baselines. After we flipped the patient, positioning the patient, started just getting the 10-10s and securing everything before even begin prepping the patient. The neuromonitoring tech noted that there was a loss in MEPs and decrease in amplitude less than 50% of the I think at that time it was about 25% decrease in the amplitude of the SSCPs. So the thought process is, do I flip the patient? And looking at the, now we're comparing fluoroscopy to the CAT scan because we had no previous x-rays. There's a concern. I was concerned that it may have displaced a little bit. And even if it had not displaced, he had pretty severe stenosis. So there's a chance that maybe the stenosis has become a little bit more severe. So the option was either to flip the patient and start all over or move faster. And so I opted more because given the degree of his stenosis, his spine is so unstable, I decided to proceed and move as fast as we could. So did a rapid exposure. Typically my workflow is I place my instrumentation and then decompress. But in this case, did the exposure and immediately decompressed his, it was locked in. I used a Mayfield head clamp. So he was locked into the bed, and I immediately decompressed the spinal cord, took off the top of C2 and part of C1 and the top of C3. There was return of the SSCPs post decompression with increased MAP, but no significant changes in his MEPs. So post-op baseline strength after the surgery was normal, but I'll go ahead and show you what we did. I lost the this is the intraoperative X-rays. And so I did an occiput to C5 fusion with the decompression. And for unrelated reasons, because he also had a partial vertebral, like a vertebral dissection. So even this MRI was only obtained by the neurosurgeons following up his vertebral dissection. So, but the MRI demonstrated, this is me, I think this is about 6 months after surgery, demonstrating the adequate decompression. But post-operatively, he had a normal strength post-op after we finished the case. That's it for this case.
Emmanuel,
Emmanuel,
what was
sorry.
his horizontal, I'm sorry, Jens, I was just going to ask what his horizontal gaze was before. It doesn't look like he was acutely kyphotic, but sometimes you can use a fracture as an osteotomy as long as you don't kink the cord. But it doesn't look like he needed it. It looks like the position you had him in was the right one.
Yeah, no, I think we maintain his position, his baseline position.
So my question, so another dramatic case, another exceptionally well done patient's problem resolution. But for me, the first big thing again is clearly, obviously, you did some angiography or I don't know what it was, MRA, CTA to look at his verts. So what was the story there? Was it a Biffle 2, 3, or what was the grade of the vertebral artery injury? And how did that influence your choice of posterior hardware?
So it was strictly it was a dissection, and the neurosurgeons felt they didn't think it was anything to be too worried about. Just typical, be cautious instrumenting. I rarely use navigation or robotic surgery, but on this case, particular case, I decided to use navigation because the anatomy, for those who do freehand, is it's easier and straightforward to do when you have a normal anatomy or even a revision case. You can sort of create that normal anatomy. As I joke with the residents and the fellows, sometimes it's like now the spine looks like a spine after you've taken out all the extra bone and osteophytes, and even though they look at you and they say, I still don't see it as a normal spine. But in this particular case, I opted to use navigation just to make sure that we can instrument given the poor landmarks from the autofusion.
In your history, you used a term that I hadn't heard in a couple decades, girdle stone. Yes. I had to think about it because it's not something that's bantered around very often in current presentations.
Manny, can you go back to the, I'm sorry.
No, go ahead, Bob.
Can you go back to the initial injury CT scan? What scares me the most about these rigid spine fractures is the positioning on the table. And even with these cranial-cervical dissociations or low cranial or low dissociations, the flipping of the patient concerns me. And the way I typically do it is I use the Jackson table, I use the Mayfield, I put the patient on the flat top Jackson table, I attach the Mayfield, and then I rotisserie them. But even with that, you're still worried about a little motion. With these rigid spine fractures, if there's any way that I can get a plate on the front of the spine before I flip the patient, I'll consider that. And I would say that you don't even have to put a graft in because it's a bone forming condition. And the reason for the plate is just to prevent that motion with the flip that occurred here. So looking at the CT scan, I'm wondering if I got ENT, could I get 2 screws above? Maybe not, but that's the first thought I would have here is, can I stabilize the front before I go through that dangerous flip? That's my only thought here is, can you get a plate on? Could you put 2 screws into the top of C2 there and then put a little long plate on like a buttress to prevent this thing from moving a lot when you flip the patient, and then do your posterior procedure? That's my only thought on this. You definitely have to do a posterior procedure, but is there any role for just a short anterior procedure just to get some provisional stabilization to make your flip a little safer? That's all. I'm not so sure you can get it. You have to really look at that CT scan and study it. But very difficult case and very nice job that you did.
Yeah, Dr. M, I think the first case of OC dissociation I saw was a 28-year-old male motor vehicle accident, not wearing a seatbelt, went through the windshield, but completely neurologically intact. And I used the rotisserie technique, locked him up on the supine on the Jackson frame, and on a Jackson table, flat table, and then put the frame on top of him and rotated him around. I think that may have been the only time I used the rotisserie. In his case, I had a cervical collar, and after we applied we put the Mayfield on, locked his cervical collar, made sure it was real tight, and just relied on it maybe to provide some false sense of support as we flip the patient.
There's no room for the cord, and all the motion is centered right at the fracture site. So that's what's really daunting about this case. Amazing that it's neurologically normal.
Hey, Manny.
Sorry, you
Manny,
go first.
What was the length of time when you saw the MEPs go down? I mean, how long did you think about, okay, if I flip them back over or just go straight ahead? And then what was the time frame once you made the incision and you got your decompression done?
I think so. When we're notified about the loss in MEPs, I'd position everything. I typically do a scout images, just a lateral to localize the levels I'm going to expose. Put a little spinal needle through the skin. And I think we just finished doing that when the neuromargin tech mentioned that. And it was really, I think that decision was made within maybe less than 30 seconds. Because I've lost signal, but I have this, and in your brain, it's like, I have to make a decision right away. And it was just, let's go. And I was already on my way out to start scrubbing in. So I just went out, scrubbed, and came back, and we moved, prepped, draped. And I think we're down on skin and decompressing the spinal cord within 30 minutes, 20, 30 minutes.
On that note, by the way, Michael Feelings and his University of Toronto group had a great Global Spine Journal Club last Wednesday evening, and they talked about, for instance, motor loss and intraoperative neuromonitoring, and the recommendations nowadays 85 millimeters plus mercury, of course, and so there's a whole lecture about how to handle the various declines intraoperatively, but that was beautifully handled. I'm going to defend Dr. Menga from an anterior surgery first. So this is a complete craniocervical fusion, as you said, and I can't imagine trying to do a full acute submandibular approach to get that. I totally get what Dr. Molinari says. It's frequently nice in these angst patients to do a temporary anterior fixation, take the sharp bone edges off the esophagus. By the way, they can have a spontaneous laceration from that sharp razor edge. But that would be a very complex surgery done in a patient where basically the entire occiput is fused to the upper C-spine segment. So I commend you for going just posteriorly, Emmanuel. I would have not wanted to, or not had the chutzpah to go anteriorly first. But really well done. And in addition to the angst the vertebral artery injury on one side being a burden, this is very well done from posterior, I think.
Thank you. Thank you. All right, we're going to move over to the star of the day, Dr. Molinari.
Okay, let me share my screen here. Give me a second.
Manny, those were great cases. I think that was a star too.
I was going to say, yeah, speaking of a star, I mean, those are two
I learned
cases.
from the best.
Okay. Okay, Manny, if you stop sharing, I'll share mine.
Oh, yes. Thank you.
You got it? Okay. Okay. Let me see. I'm missing one. Let me, give me a second. I have to pull up one image. Hold on. Okay, here it is. Okay. I don't see it. Yeah, I'm having a problem pulling this one up. It should show and it's not. So let's see. Okay, here it is. Let me share. Okay, I apologize here. I'm having a hard time trying to share my screen. Here it is. Okay, I got it. Okay, can you all see this?
Yes.
Okay, so the reason I like taking spine trauma call, and I've been doing it since 1997, is because you never know what you're going to get, right? It's like that box of chocolate. You never know what you're going to get. And you have to think, you have to process the case, and you have to make some treatment decisions and execute your game plan. So this is a patient that came in when I was on call duty. It's a 13-year-old female who fell from a trampoline, and she had neck pain back in 2012 on 5 February. And she went to an outlying hospital. She had these x-rays done. They were read as normal, and she was sent home, but she was given a collar. So she went home. She had some pain. She took her collar off, okay? And then she came back 5 weeks to the same emergency room with worsening neck pain. And they took these x-rays, and they said we should send her to the level 1 trauma center in our region. And we're the level 1 trauma center, and I'm on call. So this is a 13-year-old girl who came in. She's completely neurologically normal. She has a lot of neck pain, and she has these x-rays. Here's her CAT scan. And that's me up in the top left corner now. So it's completely off coronally. It's about 45 degrees angled in the sagittal plane, and it's about 50% translated. And the question is, what do I do? This is 5 weeks out. She's having a lot of neck pain. It looks like she has some bony stenosis up at the C1, C2 region. And what do you do? So I'm going to put this out to my expert panelists, because I know we have some really good expert panelists on this. How do you want to treat this?
Well,
Dr. Lieberman, Dr. Lieberman.
I'm 30, 40 years past this, but we would have done it, put them in skeletal traction.
So you would put this in skeletal traction. Would you put pins in her head?
Yeah, would have put Gardner-Wells tongs and just started with about 5 pounds, go up 5 pounds at a time and see if you can get some reduction.
Do you worry about the Gardner-Wells tongs? They're calibrated for adults. Do you worry about that in a 13-year-old kid at all? Or do you change your technique for putting them in?
You know, it depends kind of what their 13-year-old's level of maturity. Sometimes girls are a little more mature than boys. I don't know. I can't answer that. Jens, you said traction also.
I was trying to bait Dr. Lieberman into halopelvic traction or something like that, his Toronto roots. But I would absolutely do traction first. I would admit her. I'm worried about social circumstances there leading to neglected care. A 13-year-old with a neck fracture should not be taken off her collar. But I would do a 6-pin halo to address Dr. Molinari's realistic concerns. Probably not an 8-pin, depending upon her compliance, but a 6-pin halo, and I would give her progressive traction. Absolutely. First order business.
Right. So that's what I did. That's what I did. But again, you know, her mother was there. They were arguing. She was anxious. And I like halter traction in kids. I like putting the halter on, and you can use it in young kids. You don't have to use a lot of it, you know, up to 10 pounds or so. The kids tolerate it pretty well. So I put her in halter traction with the thought of seeing if this is mobile or not. Again, it's 5 weeks. So how mobile is this? And this is the first cross table lateral I got with 5 pounds of traction. So I looked at that and I said, that does not look that bad. Right? Does not look that bad. So now the question is, do I change how do I get her out of the traction, and what type of halo do I use? So I like this halo in squirrely kids. It's a non-invasive halo. It doesn't involve pins. It has a strap. It has a chin plate that's somewhat uncomfortable for the kids. But again, it does hold the fracture in position, and it's easy to apply, and it doesn't involve putting pins in the skull, and you don't have to do this in the OR. So I did this at the bedside. I put an extension posture on it, and I was thrilled with my reduction at 5 weeks. So
Bob, you're a nicer, kinder guy than me. In a patient who's previously removed her collar under
Yeah.
dubious circumstances, my only thought would be 6 or 8 pins. I'm a very mean person here, but you're a very nice guy. Unusual for a New Yorker, but that's
Jens,
that's
you're
just
clairvoyant. You're clairvoyant, and there's a reason I'm showing this case.
Well,
It's not a
plus being a
simple,
little-
there's a reason.
Yeah, plus being a little type 2-ish of a fracture, you know, I mean, I don't know about kids because I don't have a lot of experience. You know, this may be one that's going to be tough to heal non-invasively.
Well, especially at the 5-week CT really showed no bone
Yeah.
healing at all, and it's still mobile at 5 weeks. You're in for a long haul here if you're going to treat this non-operative.
Would you fuse her, Jack? At this
Yes,
point, would you just fuse her?
yes.
Scott, you would fuse her?
Scott?
See, Scott, would you fuse
Yeah,
her?
I mean, like Jack said, 5 weeks, even if it healed in a malunion, you'd have expected it to heal by now. Type 2, you know, yes, I don't know what the most modern technique might be to do it, but, you know, I would be more aggressive in this situation.
And Bob, let me ask a question. Is it still in vogue to do a single screw through the base of C2 anteriorly
Well, let's
rather
go
than
back.
having to do a C1, C2 fusion?
So we'll go back and say, you know, you could you listen to Andrew Daly, and he says he had a lot of complications doing that screw technique. That is an option. It's an operation, but it is an option. Okay, it is an option. So we have a vote for maybe a anterior odontoid screw. We have a vote for a posterior C1 C2 fusion. And I'm going to show you what I did. So this is the non-invasive halo, and Jens mentioned that this child may be non-compliant, and there may be some social issues contributing to that. So here she is, 1 week status post the halo. This is 2012, Jens, and this is 1 week status post the halo. It's now 6 weeks after the injury, okay? And it redisplaced, and she's back in the office with her mom. So now it's 3 o'clock on a Friday, and I'm looking at this saying, it's displaced again. What do I do?
And did she take her non-invasive halo off?
She did not take it off. No, she didn't. Her mom swore she didn't take it off. And I'll be honest, there was some motion around the strap in the front and her scalp. So I thought it wasn't as tightly fit as I'd put it on.
So from my learning from non-operative care from odontoids, what I have done to predict instability, assuming that they're compliant, and I've made my point before about 6 versus 8 pins, I get a lateral recumbent and a lateral upright. If there is an acceptable minimal motion, then I find that good. By the way, these kind of odontoids I would reduce under fluoro with the patient asleep, and then literally Jack C1 back, sorry, Jack Ziegler, put the odontoid posteriorly displaced back onto the base to get the best possible kind of a military tuck position with a slight extension. But the lateral upright, lateral recumbent helps me greatly predict these kind of instability patterns, provided the patient's compliant.
So this is definitely unstable. I knew this. It's now 6 weeks after the injury. I'm not 100% sure I'm going to reduce it again. And I don't want to take away 50% of her rotation by doing a C1, C2 fusion in a 13-year-old kid who may want to play sports or who may want to engage in significant physical activity. So I was really trying at all costs to get this young odontoid to heal. And young odontoids should heal if we get them in position and we correctly immobilize them. So the question is, what do you do here? And believe it or not, I adjusted the halo. I did the same thing. I read the riot act again to mom and the patient. And I said, look, we're going to give this one more shot. If it moves, I'm going to have to do a big operation on it. So here she is. This is her at 6 weeks now. She's back. I got it reduced. Here she is at 7 weeks. I got a CAT scan, and I'm all at 7 weeks. I'm starting to see some callus here. It's not perfectly reduced, but there's definitely some callus. Here she is at 9 weeks. The x-ray shows with the non-invasive halo, it's still relatively aligned, and I would argue it's acceptable alignment for a child who can remodel. Here she is at 16 weeks after the injury. I left the halo on for a full 12. I put her in a collar, and then I took the collar off and CAT scanned her at 4 months. And this is the healing. So you can see it's completely healed. It's solid. It doesn't look straight, but it works and it's functional, and she has a good range of motion. And here she is 6 months after the injury with flexion extension views. And I would argue that this is the best way to treat pediatric odontoid fractures, is to do it without surgery, to get them aligned and to immobilize them. You could argue, Jens, that you should have put pins in the head and it would have held it and it wouldn't have slipped. I'll accept that criticism. But the bottom line is the dictum is go with the halo, go non-operatively, and the patient healed.
That's amazing result. I have never heard of this halo that you're talking about. I mean, it's way past my time. Have you guys ever heard of it?
So I do use the non-invasive halo in young kids. I'll try it first and I'll see if I can get away with it. I wouldn't use it for anything that's a cranial cervical dislocation, anything where I really had to limit all motion, but kids seem to tolerate it and it's easy to apply.
No, I think that's great.
That was a great result, Bob.
Yeah, Dr. Am, what's been your experience with the, I've used it a couple of times today in Rochester. One was a patient, I don't know if it was related to the traumatic brain injury he also had, and had like a bony avulsion of his transverse ligament. And I initially began with a non-invasive halo, but which I don't know if it's related to the fact that he had a hard time communicating the pressure, but he developed a pressure ulcer from the non-invasive halo over his chin. So I had to switch to invasive halo, which worked out well for him. Have you seen issues with that, with the pressure?
So yeah, they do have some issues with that chin post. And again, if that's a problem, then you have to convert to a halo. But as you know, Manny, we use the most halos in all of New York State by a very large factor. And we have 2 patients who had cranial cervical dissociations, Harborview grade 2 injuries where there's a big diastasis, and patient wasn't healthy enough to have surgery acutely. We put them in a halo. We left the halo on and then put them in a collar. And believe it or not, the joints became rigid and they didn't have instability after we took the halo off and waited 5 months with non-operative measures. So we have 2 patients now with unstable cranial cervical dislocations that we treated in the halo. Jens, you remember the first one I published in the Global Spine Journal and you reviewed the case. We now have a second one. So again, does the occipital cervical joint, which, the capsules are the main stabilizers, right? Does that behave like a dislocated orthopedic joint when you immobilize it for a long time in a very rigid halo? I don't know. I have 2 patients now who became stable with non-operative management.
With enough head injury and recumbent in an ICU bed, the sky's the limit. HO will do the rest. So I know of some of those cases that are incidental and we can't extrapolate from those. But again, in principle, most of these patients are in vital threat, and stabilizing the cranial-cervical junction actually also has been associated with a neurologic recovery in case of significant neurologic injuries there. So I would not write off surgery, and it really requires that the patients stay down. We published on our kids with cranial-cervical injuries, we had 3 of them, and we just kept them at bed rest in halos, and they actually healed quite nicely. My one question here for you is, Benny Jeannery, the famous Swiss surgeon from St. Gallen, always talked about these peptidontoids, even if treated non-surgically, actually fusing into C1. So these patients don't have normal range of motion. And I know that for adults, he did actually rotational CTs. How is that in kids? Do they have a normal left-right rotation, or is that partly ankylosed or fibrosed?
this patient, Jens, you can see her flexion extension, her rotation. I didn't measure it with a goniometer, but it seemed, pretty decent to me as she was able to turn her head. She was able to make a circle with her neck without neck pain. So she had a good functional range of motion. Could she have lost some rotation? Quite possibly she may have, but I would argue this saved her a C1, C2 fusion.
Hey, Bob, I really admire your persistence, but I wonder how many people out there after the first time she came back would have said, well, okay, now we have to do a fusion. And I got sort of the idea that Jens was thinking about that. And I don't know about Scott, but I really admire you sticking it out. And you got a great result for her. And she has a mobile C1, C2.
Oh, thanks.
Hey, so first of all, Dr. Kakarika asked about halos and elderly. There's a whole subject. We could fill hours on that, but in principle, most of us don't use halos in elderly anymore. Aspiration risk and soft tissue breakdown, because the torso fit is the most important thing for halos. So I think nobody that I know of in the US, certainly, I think Canada also would use a halo anymore on an elderly patient.
Okay, Jens, I got to interrupt here because we've published 2 papers now. And as I said, Manny, right? We use a lot of halos. We do use geriatric halos. And, there are 2 studies, the Tajan article is one of that show incredibly high complication rates. And the board answer is it never, ever, it's anathema to put a halo on someone over 65. Well, sometimes you're caught between a rock and a hard place with these odontoid fractures, these hangman fractures, and you don't have an option. Patients are too sick for surgery, or you just don't have the option. So in Rochester, we have a series of patients over the age of 65 who we have placed halos on. We published with the Disu Mesfin on our C2 injuries, and we commented on it. And we have a dedicated geriatric halo study that we're doing now. They do have complications, but they're much less than what's reported. So Jens, I would tell you that we have experience with that here in Rochester. It certainly contradicts what's out there in the literature, but it has not been our experience that in the right patients, the complication rates are as high as Tajan reported.
Hey, we got the same publication. Bransford was the first author from Harborview. I forgot it was 183 patients or so, and we did them in older patients also. We also did not find age to be a negative predictor, but again, the general consensus has become so negative. I know we need to move forward, and one other question by Nick Minisali was hard removal after C1, C2. I would not do that. For a pediatric patient, I would actually, if at all anatomically possible, do a transarticular screw sterile to not have a big rod screw set up in the back. But I don't know what you think about that. I know we need to move on.
I'll just make one comment about pediatric patients. Rick, you commented on my perseverance here. I'll do everything I can in a young patient to try to get their fracture to heal, especially upper cervical spine fractures without fusion. Again, I think it's a huge hit to fuse C1, C2 in a young kid if you don't have to. So I'll do everything I can to try to get that fracture to heal without an operation.
That was a great illustrative
case
for that point. Yeah,
All
thanks,
right.
Bob.
So keeping with the theme, right, Manny, and you know this theme because you were here with me for many years, right? You can't pick and choose your cases when you're on trauma call, and it makes it exciting for someone who's been doing this for 30 years. It's still exciting for me to go in and to see, what the fellow and the resident present in the morning, and to make decisions on treatment and execute those decisions, as I said. So this is a 50-year-old morbidly obese male who was in a motor vehicle accident. Comes in with neck pain. He had multiple orthopedic injuries, as you can see on the screen, displaced pelvic fracture, tibia fracture, forearm fractures, but he also had this odontoid fracture, right? If you look at it, you can look at the CT cuts. You say, well, it's non-displaced. The guy's morbidly obese. You can see the neck folds posteriorly. I think we would all agree that this patient probably is best treated with a collar. Would everyone agree to that? Is there anyone? Jens, you disagree with that?
Absolutely. Rigid collar, set him up, see what's going on.
Of course, of course. So we put him in a rigid collar. Our orthopedic trauma colleagues wanted to get the patient, polytrauma, wanted to get the patient to the OR. And we said, okay, maintain C-spine precautions. And, this is what the patient looked like. And that's a body habitus. And you're certainly not going to use a halo in that body habitus, right? So we said, okay, let's put the patient in the collar, maintain C-spine precautions, and go ahead with your orthopedic procedures. So they go ahead with their orthopedic procedures, and the patient requires emergently intubation after they put the patient back from the orthopedic surgical table back onto the patient's bed. So the anesthesiologist puts in traction, puts in the device to lift up on the chin, and sure enough, intubates the patient. But what happens? Patient's not able to move. Patient's not moving anything. So I get called. I'm still in the hospital. It's 9 o'clock at night. And they said, hey, Dr. M, this patient with the odontoid fracture is in the recovery room now, and he's not moving anything. So I said, okay, let's rush him to MRI. And these are the initial MRI images that I received on the patient. You can see this big gap at the fracture site. There's a big area of spinal cord injury here, right at the level, and he's not moving. I got a CT scan, and you can see the anatomy of the fracture displacement. So the question they had for me is, okay, Dr. Molinari, how are we going to proceed now? It's now about 11 o'clock at night. I have both imaging films. The patient is not moving anything, okay? And does not have any sensation. So Jens, you said MAP goals. We routinely do that, right, Manny? We routinely get the MAP goals up. We give them some Decadron. Is anyone going to give them anything more than Decadron? No, Jens, are you going to give anything?
I'm still a NASCA's 2 proponent. This is a whole other evening's worth of discussions.
Sure, but what are you going to give, Jens? And what are the special?
I'm 30 milligrams per kilogram. Methylprednisolone bolus over 1 hour, 5.4 milligrams per kilogram per hour, 23-hour drip. And I'm going to take him to the OR that night. I've had the literally same case, and then about a 17-year-old massively big girl who had a missed C1, C2 internal decapitation injury. So this is de facto, again, like not a type 2 odontoid fracture. And that's not very big. That's normal.
So where's the compression? Because I see the fracture gap, but it's not terribly malaligned.
There's this.
So, I mean, there was obviously a spinal cord injury. There was some trauma to the cord, but it's a little bit narrowed at the fracture site, but it's not like so grossly displaced, like I've got to go back and do an open reduction.
No,
right now.
You got to stabilize
For me, this is
it,
an unstable cord. This is an unstable cord neurologically and structurally. It's just basically the odontoid is gone and he's lost his C1, C2 ligaments. So there's nothing holding that in place anymore.
It might have been the intubation maneuver.
So you think this is just like
hyperextending.
we're looking at a static picture that looks relatively well reduced, but when it was intubated, they dinged the cord.
Yeah, when they put the glide scope in and pulled up on him, like they had to emergently intubate this guy, and he's a very difficult intubation. In fact, you can't even see his neck in here. His head is recessed into his chest. So, it's 11 o'clock at night, and I'm up and I'm looking at this guy saying, he's got a major spinal cord injury now. And Rick or Scott commented that, hey, you know what? There's not that much ongoing compression there. There is a significant primary injury from the intubation. Okay, he does have a significant spinal cord injury, but I don't know if it's the best thing to rush this guy at 11 o'clock at night back to the operating room and try to flip him with personnel. And you guys all know you've operated in the middle of the night, and Emmanuel, you can tell at our institution, it's a chore to operate in the middle of the night. You're dealing with people who aren't familiar with the instrumentation. They're not familiar with spine setups and the whole range of problems that come with that. So I try to do everything I can. If I can avoid operating in the middle of the night, I try to do everything I can to avoid operating in the middle of the night. But with that said, I'm looking at this saying, all right, what's the best way to do this? How am I going to do this, and how am I going to do it safely? I'm looking, how am I going to get into this neck? Again, the head is recessed into the chest. And if you look at the folds on the back of his neck, you can see, there's still folds back here. So So Jens, you said you would do this posteriorly, correct?
Yep, 3-inch tape.
Okay,
Miracle cure for folds.
okay, so 3
Tons of
inches.
it.
So tell us, Jens, how you deal with those folds.
The usual shoulder pull down. I would probably not even do him with middle of the night. I would not even use neuromonitoring, just to keep saying I need to get done what I need to get done. I would position him prone, multi-person turn, not even a turning frame, because this body habitus might be a little bit too problematic. So standard double or triple tape shoulder pull down. All I need to see is down to about C4. I obviously shave everything, and I put transverse 3-inch tape across the skull, and then staple it down like 10 staples, and pull up on that tape so I can get a rostral pull. And then I again use tons of benzoin, let it dry up, and do multiple vertical southern tapes over the neck area, left and right of the intended incision area, so I get the shoulder folds out. I can literally, I don't want to jinx myself here, but I can get the skin folds out and get a nice glut neck, smooth baby skin neck, and even the biggest people with taping like this.
Okay, so and question is, what are you going to do here? I thought about this long and hard. I did not operate that night. I thought about it all throughout the night, and you don't sleep very well when you have these cases, these trauma cases that come in that challenge you. So I didn't get much sleep. I thought about it. I went back in his room the next morning. He wasn't moving, still intubated. Okay. And I said to myself, what if I did nothing? What if it was like the Texas guy said, when you go back here, you look at the pressure on the cord, there wasn't significant ongoing pressure, in my opinion. And I said, what if I kept him on the steroids, kept his MAP goals up, and just watched him? And especially if he's going to stay in the ICU like this, I have some time. And lo and behold, that's what I did. And here he is at 6 months. He healed this thing. He healed it, and here he is at a year with flexion extension films that show this is completely stable. Now, okay, in that year and a half, he lost about 150 pounds. So he did wind up suing the hospital, and it did go to trial. And when he showed up at trial, he was, a shadow of himself. He was essentially a toothpick. And the attorney said to me, he said, Dr. Molinari, had you not taken these pictures, the outcome of the case would have been a lot different. He did completely recover, okay, but he did have a significant loss. He was in the hospital for a long time. He lost his job, and he suffered significantly. But the attorney said to me, he says, Dr. Molinari, the fact that you took those x-rays for your planning purposes really was instrumental in defending and presenting the case. So he had a decent outcome. Was lucky. And the reason I show this and the other cases, sometimes with these complex trauma cases, the best thing to do is to let them heal. And that's what I did. No.
I have a
How long
question.
did you keep,
Dr.
how long did you keep him in the
Heyman,
collar, Bob?
I kept this guy in the collar for a long time. I think he was in the collar for about 6 months, believe it or not. But he wasn't moving very much, and they would take it off to bathe him. So I left him in the collar for a long time. And here he is. As I said, here he is at 6 months. He's completely healed. I did the CT scan at 3 months, and then I did a CT scan at 6 months. But this shows that this healed. And you can say, well, you got lucky. Maybe I did. I just was worried that I was going to have to position him again with the spinal cord injury, move it, and incur more injury to his spinal cord. So again, he healed. Could I have done a C1, C2 fusion like Jens suggested? I could have. Would he have recovered faster? Maybe. He might have. But I did this, and I show these two cases tonight because, as I said, sometimes the best option is one of the most acceptable options is not to operate. And both these cases showed that you can do that and the patients can heal.
Jens, a
Fabulous.
question for you regarding positioning with the taping. I've had a patient similar to this, similar size, seems routine for us in trauma call in Rochester, but with epidural abscess in the cervical spine, and anesthesia was reluctant about us having the patient prone. And so I knew some of my neurosurgery colleagues would do posterior cervical in the seated position. So luckily it was only about 6 p.m. at night. So I got one of the neurosurgeons to help me position the patient sitting down, and did the surgery with the patient sitting down. Is that something you would consider for a patient like this size, to at least have the shoulders drip down so you can get into the cervical spine?
Go ahead, Jens.
No, I would just do what I said. I mean, I've done these more than I want to think about. And Dr. Molinari is completely right. These are nightmare cases, especially at night. But I just like the biggest possible predictability for the patient. What you've done is amazing. Just one question, Dr. Molinari. Why did he litigate? Was that around the spine or the spinal cord injury? What was the substance of his complaint?
He had a major spinal cord injury. He was in the hospital for almost a year. He had rehab. He lost his job, and his quality of life significantly diminished because of what he perceived was a complication from his care in the hospital. He came in completely, so keep in mind, he came in completely neurologically normal with a non-displaced odontoid fracture.
Yeah.
He was placed in a cot, was taken surgery, and he didn't move. He didn't recover his neurologic function for about 6 months.
Yeah, amazing case, wonderful. I mean, again, he could have stroked out or had mass bleeding from my surgery, wound infection, something like that. So we don't know what we don't know until we've done it. I think that hit the best possible treatment in all regards. And congratulations on the wherewithal to show to show non-operative care being so successful.
Great cases.
Thanks, guys.
That was a lot of fun.
Thank you, both of you. Really appreciate it. Yeah.
And please keep.
Yes.
So
I love the decision making for you both.
very thoughtful, great cases, both from the University of Miami and the University of Rochester. Dr. Menga, Dr. Molinari, we thank you very much. A lot of fun, great discussions. And again, sometimes it's just using our best possible wits and wherewithal. We thank the audience. We had a lot of people from around the world. We appreciate your interest, and please sign up for next month's great arthroplasty forum led by our wonderful colleagues, Dr. Ziegler, Dr. Blumenthal, and Dr. Geyer. So please do join us next month for an all-star symposium on motion preservation. And with that,
get your CMEs, text 1278. Thank you for joining us. And thank you again for
See you next time.
Great cases.
Thanks, Jen. Thanks.
Good night, everybody.
Thanks, everybody. Have a great night.
You too.
See you, Manny. Thanks, Manny.
Good night, everybody.
Thanks,
Take
Dr.
care.
M. Thanks,
Get
Jens.
some sleep, Bob.
I know you guys.
Dr. M, we have another one coming up, right? We'll plan for next year.
It's up to you. Whatever you want, man. I'll always be your wingman. You know that, right?
All right.
Anytime you want to do, just let me know.
Okay.
Have a great night. We miss you, Manny, very
You guys
much.
are great.
You
Take
too.
care.
Thank
All
you.
right, take care. So long, guys. Yep.
Enjoy the water view, Manny.
Thank you. Thank you, sir.